Or you want to?
Let's, I need to plug this. Where's the plug here?
I just sent it to you.
Okay, let me look for it.
And feel free to turn off your video and your audio until I introduce you. But even when you attach your background, you can still see yourself even if your video is turned off.
Okay.
Thank you.
Thank you.
The background is easier for you, Deborah?
Let's see. I'm looking at the new email that was sent. Let's see. Oh, here's the new email.
I remember this young lady, she had just gotten vaccinated. She's African American, and she goes home and she talks to her grandmother. Grandma, you need to be vaccinated. Grandma says, absolutely not. I don't trust the healthcare system. I don't trust any of these people. I'm not going to get vaccinated. The young lady says, well, Mom, the lady who vaccinated me is African American. She says, well, in that case, take me, I want to get vaccinated. The message is important, but so is the messenger.
Data and science and study have shown that African American individuals are much less likely to be enrolled into a clinical trial. So the EQB Med initiative is going to address this major and critical problem in our community.
EQB Med initiative positions us at Texas Southern University to actually have access to innovative and breakthrough clinical studies. We do a lot of work to increase awareness about clinical research participation, but without an opportunity to actually open access for individuals to participate and to build trust in clinical trial process, we are very limited.
Pharmacy is a very important team in communication with the community. And we are not only have a PharmD program, we also have a PhD program. With that, we have more outreach to the community.
We are the #1 producers of African American pharmacists in the state of Texas. Pharmacists are a significant part of the healthcare team. They're able to immunize patients. They're able to help them in a variety of health settings per se.
TSU had the RCMI support back in 1980s, especially in terms of research infrastructure. So the student and scientists can conduct most cutting edge of research, especially in the area of drug discovery and development.
In 2024, the College of Pharmacy and Health Sciences celebrated its existence of over 70 years. We lead a lot of initiatives advancing health equity, training community health workers, providing continuing education for community health workers, as well as for our pharmacy and health administration students.
In this initiative, we are going to partner with UTMB, Yale University, and Morehouse School of Medicine. We will be able to gain more experience and resources and guidance on how to recruit for clinical trial and how to conduct clinical trials.
So this clinical research initiative under the EQB Med funding mechanism allows us not just to provide opportunities for clinical trial participation for community members, but it creates a platform for us to train the next generation of pharmacists that will be culturally competent, that will have an high level of awareness of engaging with community members to promote the concept of diversity and equal representation in clinical research participation.
Hello, my name is Veronica,
Program Director of Texas Southern University's Breast Cancer Screening and Prevention Center, where we transform women's health in breast cancer care and provide mental health services in underserved communities.
In the past 3 years, we have provided mammograms to over 1,400 women.
We have reached women in their neighborhoods through mobile mammogram services,
eliminating barriers like transportation costs and access to care.
Our holistic approach doesn't just stop at screenings. We provide navigation, care coordination, and treatment assistance, ensuring no woman is left behind.
We also provide breast health education in diverse languages, addressing anxiety, concerns, and misconceptions about mammograms.
We have established a vast network of over 100 partners, received 5 proclamations, and fully executed over 10 memorandums of understanding.
What sets us apart is our grassroots engagement. We build trust in our community, combining cutting-edge technology with personalized care.
Our vision is to expand our reach and ensure equitable access to breast and mental health services to underserved women.
We believe in saving lives, strengthening our communities, advancing health equity for all women.
Hello, everybody, and I am going to share my screen now, but you are all welcome to today's quarterly webinar, and it is titled, give me 1 second. Can everyone see my screen? All right. So today, please, you're all welcome to Texas Southern University's Breast Cancer Screening and Prevention Center. Of course, we are supported by the Cancer Prevention and Research Institute of Texas. And today's title is our part 2 of Is Screening Mammogram a Painful Experience? Thank you all for joining us over your lunch hour, and we do appreciate your presence with us. We had the first session 2 years ago, and it received so much support, and people were asking for a part 2, and we do not want to disappoint you, so here we are. I'm going to be moving on to who we are. Under the leadership of the principal investigator for this program, Breast Cancer Screening and Prevention Center, and also the program director, Dr. Veronica Ajewole Muema. We first received our first funding from the Cancer Prevention Institute of Texas, or CPRIT, back in 2021 for $1 million to provide 3 major things: breast cancer screen and diagnostic services, patient navigation and barrier reduction services to both uninsured and underinsured women. And then also, the third arm of our program is to provide breast cancer awareness and education, hence this webinar today. We thank you all for joining us, and you are also I'm just so delighted to also again let us know that we are actually in the second cycle of our funding, where we received $2 million over the next 3 years, starting from June 2025 to May of 2028, to provide the same services, but to an extended number of women. The first grant was for screening to 1,350 women. And this new cycle, we are pleased to say we plan on providing screening to over 2,000 women. And we are also servicing women in 9 counties: Harris, Grimes, Matagorda, Walker, Wharton, Brazoria, Galveston, Polk, and Trinity counties. And this is just a data showing what we have done from March 2022 to February of this year. We are honored to have provided screening mammogram services to over 1,900 women and counting, education to 5,300 people, and navigation services to 6,100 people. Next slide, please. All right, and then this is just an introduction to our breast cancer Screen and Prevention Center team. Dr. Ajewole, you see up there, is our principal investigator and program director. We've got Dr. Annalise Gonzalez, who is our breast medical oncologist. And we've got also our other team members, and we're very glad for their support. Thank you to our team. We appreciate your support for our program in serving our women in various counties. Thank you. Next slide. Just want to also just highlight our TSU mobile health unit. Also under the founding director, Dr. Ajewole Muema, we have this TSU mobile health unit initiative. So it's on ground, it is fully furnished to provide both mammogram screening services and prevention services as well. Also, it is telehealth ready. So please, if you know of anyone who wants to partner with us to make this, to bring this to a reality, to bring it out into our community and serve our community members in our various counties, please feel free to reach out to us. The link that is posted in the Q&A session is also the same link where you can go in and learn more about our mobile unit. Thank you. Next slide, please. All right, so this is our, also under the leadership of Dr. Ajewole Muema, we are pleased to say that back in 2025 of May, we launched the Clinical Research Registry under the Center for Clinical Research and Translational Services. And what is this? It's just pretty much a database where participants enrolled or registered, those who are interested, and their information is stored so that over a specified period of time, you tell us if you want to stay, you tell us if you change your mind and you want to leave. But pretty much with this information, we're able to link people, interested participants, to research that is going on to participate in clinical research. There are over more than 250 people that have indicated interest, and over 120 people that have fully consented to be part of this. Again, there is more information on the same link tree, and you can also scan on the QR code to learn more about it. But we are pleased to have started this up, and this could not have been done without the help of you, our partners at UTMB, and we're grateful for this partnership. Thank you. Next slide. Again, thank you all for joining us. We appreciate you all. Please post your questions in the Q&A box. After the education piece, we're going to have a panelist portion whereby we'll want to take your questions and have them answered. But peradventure, perchance that we're not able to get to you because of the number of questions, we will post the answers on our link tree as well as send it out via our MailChimp. So please go ahead and scan the QR code and you can do what needs to be done. Also, the survey to this, to you telling us how we have done. So after all of our breast cancer education events, we do have surveys, and please, the survey is important for us to know how we're doing, what we can do better, and also providing feedback to our funders. Now, so our community health workers, you are going to be getting 1 credit hour of CE, but please, you have to fill out the survey and the evaluation to get credit. So again, the QR code or the link that is sent out in the Q&A will give you access to those to the survey, the evaluation, as well as our breast cancer education survey. We are streaming right now live on Facebook and YouTube, and we invite you to share, to stay connected with us and follow us on social media. Also, please subscribe to our mailing list. Go ahead and also view our website. It has a ton of information that you would love to see. If you have any questions, please email us at breastcenter@tsu.edu, and of course, call us if you need to, if there's any, if you would like to speak with somebody live. Thank you. Next slide, please. Again, my name is you know what? I just remembered I did not say who I am. I'm so sorry. My name is Nkechi Ogbo. I'm the research assistant professor and senior program manager for health services and community engagement, and as well as a co-program director under the leadership of Dr. Ajewole Muema for this breast cancer screen and prevention center. And without further ado, we'll go to the next slide. Thank you. All right. So again, what is cancer? Right? What is cancer? That is a name, something that many of us have asked, and many people unfortunately know about or know somebody who have experienced it. So simply put, it is a disease in which some of the body cells grow uncontrollably and then they spread to other parts of the body. So normally your body is supposed to remove cells that are abnormal or that are damaged, right, before they turn into cancer. But unfortunately, that sometimes does not occur. And then this abnormal and damaged cells, they grow and they multiply when they should not. These cells now turn and might form into either lump or lumps of tissue, which could be cancerous or non-cancerous. Now, cancerous tumors, they can spread or invade nearby tissues, and they can travel from one location to the next location. And when this happens, this is simply termed or is known as metastasis. Thank you. Next slide. Just a little bit information about breast cancer. Most cancer in women, it's the most common cancer in the women, at least here in the United States. It mostly occurs in older women, but about 9% of it does occur in women who are 40 years or less. Breast cancer cases are also about 30% of all new female cancers each year, unfortunately. Now, in men, breast cancer occurs about at an incidence of 0.5 to 1%. So men are also not ruled out. And if you want to know more about it, please go to our YouTube and also listen to the webinar education we had on male breast cancer back in December 3rd of 2025. Thank you. Next slide. Just a little bit more facts about breast cancer. It is also the second leading cause of death in women in Texas. We know we like to do things big in Texas, but not in the sense of it being the second leading cause of death, right, in women. So hence this forum, hence this means in which we want to provide information to hopefully spur us to action, to do what we need to do. Now, in the year of 2024, over 21,000 new cases occurred in women. And when it comes to death rates in 2024 in Texas here, 3,535 women died as a result of this ailment. Now, when it comes to death rate, unfortunately, in our non-Hispanic Black women, there is a 41% higher chance of our Black women dying from breast cancer as well. Next slide. This is an unfortunate statistics, but 1 in every 8 women will be diagnosed with breast cancer at some point in their life. So, and that is an aunt, that is a grandma, that is a relative or a friend, a very good friend we know. Unfortunately, this is the lifetime risk. Next slide, please. These are signs of breast cancer that everyone should know, and this includes both the men and the women. And some of them include having a retracted or inverted nipple, breast or nipple pain, lumps, nipple discharge. Of course, nipple discharge when one is not breastfeeding. There might be swelling around the area. There might be redness or rash, changes to your skin texture, a lump around the collarbone or underarm. And you want to perform, you want to check your breast, if not weekly, at least once a month. Either when you're in the shower, you're raising your hands up and just checking around the area using a circle motion or up and down motion all around. Once you've gotten used to how your breast feels, when something is abnormal, when something doesn't feel right, then you are able to, of course, go ahead and speak to your primary care provider who can do a more in-depth check and see if you need a referral or not. Most times it's nothing, but it's better to be safe than sorry. Thank you. Next slide. Now, what are some risk factors for breast cancer? There are 2 kinds of risk factors. One that you cannot change, that is just what it is, and there are some that you can change by making changes in your lifestyle. So this first slide here talks about risk factors that you cannot change. Of course, your age. As we go old, there is a higher risk of that. Gender, women are unfortunately more likely to get it than men. Genetics is just how you are made up. And the history, one's mother or one's sister or one's grandma had it, then unfortunately, one is at a higher risk of getting it. Next slide. And this one, of course, are the risk factors that you can change. Reducing or eliminating your alcohol intake. Eating healthier, more fruits and veggies. Fruits and veggies have what you call many inflammatory processes, which help to reduce inflammation in your body, that can cause cancer. So eating more of these healthier foods can also help us. Reducing your weight if you need to, exercising, reducing your exposure to radiation, and of course, stopping smoking. Thank you. Next slide. Now, this chart just talks about a breast cancer in African American or in Black women. Unfortunately, the previous slides I mentioned had said that a Black woman has a 41% higher risk, right? Now, the middle age of diagnosis for a Black woman is about 58 years, while for white women, 62 years of age. And Black women are more likely to be diagnosed with triple negative breast cancer, which has a lower recovery rate. Hence, earlier diagnosis. Now, the middle age of death from breast cancer in Black women is 62, while for white women is 69 years of age. And then also when it comes to inflammatory breast cancer, this is a rare and aggressive type and is more common, unfortunately, in Black women. Now, in women under 45 years of age, breast cancer happens more often again in Black women than white women. Next slide. And then this chart also talks about the breast cancer incidence and mortality here in Texas, and this is talking about between the year of 2018 and 2022. The blue bars is what you call the incidence rate, and then the gray bar is what you call the mortality rate. Incidence is how often it's occurring, while mortality is pretty much your death, how people are dying from it. Now, when it comes to our non-Hispanic whites, if you see on the blue line, it seems like, right, they're being diagnosed more, right? But then the death rate is only 20.4, which is less. But when you look at our non-Hispanic Black women, even though their incidence rate is lower than their non-Hispanic white, you see that their dying from it is higher, unfortunately. Next slide. Now, when it comes to a 5-year relative survival, that means if you get diagnosed at a particular stage in 5 years, where are you? The blue bars show your early stage, maybe stage 1, stage 2. Your late stage is a gray bar, which is probably maybe like your 3 or 4 and onwards. Now, for all races, which is the first column we are looking at, you have nearly 100% race when diagnosed at an early stage of having a 5-year survival. Now, when it comes to being diagnosed at a later stage, of course, the survival rate drops. When you look at your non-Hispanic white, that is also similar. When you look at your non-Hispanic Black, they still have a higher survival rate if diagnosed early, as opposed to if they're diagnosed at a later stage. So what is all this saying? That means check early, call attention, speak up early, so that so if there is anything, then you get diagnosed early, and by God's grace, they get treated early. And then, of course, your survival rate or survival chance is higher. Next slide. So pretty much early diagnosis means a better prognosis for you. Now, 4 things to take away from this: be aware of your signs and symptoms. Be aware of what it is. Sometimes, it might be nothing, but it's better for you to be sure that it's nothing. Get medical advice if you notice anything that is abnormal on your screen or notice any breast cancer signs or symptoms. Then be evaluated in a clinic right away or as soon as possible. Learn any diagnosis and follow up with any referrals for treatment and services. Next slide. Now, the goal of screening is to catch cancer early, right? Finding breast cancer early is the key to improving your outcomes and closing that gap. The earlier a doctor finds breast cancer, the more likely a woman is to survive the disease. Now, screening, of course, is done by mammograms. Next slide. Now, when it comes to screening mammogram, this picture here just shows sort of what happens, and it's an X-ray of the breast that are done when there are no breast cancer symptoms. It can find early signs of breast cancer, right? It uses low-dose radiation, and typically it takes just a few minutes for it to be done. And if a mammogram finds something that is not normal in the breast, there will be what you call a biopsy or a repeat mammogram in 6 to 12 months. And then some findings are benign, which means it's not harmful and needs to be monitored. Then a biopsy can be done by a radiologist using a needle or by a surgeon in the office or in the operating room. And if there is anybody here who is needing, a referral, maybe to have a PCP or to receive screening from us, either if you are underinsured or uninsured, please feel free to even go to the link there and you will see some services there, or you can call us at 713-313-5781 and we can triage you to the services you need. Thank you so much. Next slide rather. Now these are the NCCN guidelines for risk assessment. Pretty much somebody with an average risk is one who has no genetic history that can preclude one to that, no family history, cancer history, no personal health history, suggesting that the person is at an increased risk for breast cancer. And at that time, you probably adjust screening regularly at 40 years of age every year. But if one has an increased risk, and that means maybe like you have a family history of AIDS, or when a calculated risk is done, lifetime risk is done, is 20% or more, or one has had chest radiation between the ages of 10 and 30, or maybe you have extremely dense breast tissue or some genetic mutations. Usually your screening will start earlier, maybe at the age of 30, or even sometimes as early as 25 in some cases. Some people might even need an annual breast MRI. But of course, this is something that your primary care doctor can help you to determine. You can go ahead and do what needs to be done if there is any cause for you to be screened earlier than 40 years of age. So pretty much the key thing is self-awareness. I think the key thing is also to advocate for yourself. If you feel like something doesn't seem right, something is wrong, then please go ahead and seek help, seek clarification. Thank you. Next slide, please. So remember, the focus is you want to focus on a healthier lifestyle. Stay active, eat nutritious food, limit your alcohol, and avoid smoking. And if you say, oh, there are just so many things for me to do, where do I start? One thing at a time, right? If you need to just start by limiting your alcohol, and then you now follow up with eating nutritious food once you have stopped the alcohol or limited your alcohol, then do that. But it is one step at a time, rather than you feeling overwhelmed and not starting at all. Then get your regular screenings. Mammograms do save lives and know your risk. Do your monthly self-exams, right? Know your breast, be familiar with it. Just like you can recognize the voice of somebody on the phone, you want to be able to recognize what is different about your breasts. Then pay attention to the warning signs. Don't ignore it. So watch for changes, the lumps thickening in the breast or underarm, changes in the breast size or in the shape, dimpling or puckering of the skin, any kind of nipple discharge or pain. Seek attention. Thank you. Next slide. And again, please, to our online attendees, feel free to post your questions if there are any. The survey link will also be posted online, and we're going to go on now to our panelist session, which I'm very excited for. I'm going to go on with the introductions. We've got a first-time screening mammogram recipient in the person of Dr. Veronica Ajewole Muema, who, like I said earlier, she's the principal investigator for this grant program, but she's also a professor of pharmacy practice, and she's the assistant vice president for clinical translational research and community engagement at TSU. She received her PharmD from TSU and completed her oncology pharmacy residency at Houston Methodist Hospital. She's a board-certified oncology pharmacist with clinical practice in oral chemotherapy at Houston Methodist Hospital Cancer Center, where she's also an adjunct assistant professor of oncology. She's a principal investigator, like I said, of this grant program, and she's also her passion is anchored in advancing health outcomes in the community, as reflected in her dedication and service to her family, her patients, her students, her community, and of course her church. Welcome, Dr. Ajewole. Thank you for joining us today.
It's a pleasure to be here. Thank you so much.
Thank you. And the next panelist member we have is Ms. Brittany Weston. Ms. Weston is the lead mammographer at the Rose, where she has proudly served for nearly 8 years. She began her journey with the Rose as a student, and then, of course, quickly demonstrating strong clinical skills, dedication to patient care, and a passion for women's health. Now, after completing her training, she was hired onto the team and has continued to grow within the organization. In her role, she performs a wide range of diagnostic and interventional breast imaging procedures, including mammograms, breast ultrasounds, stereotactic biopsies, ultrasound-guided biopsies, and bone density exams. Thank you, Ms. Weston, for joining us for a second time. We really appreciate your invaluable experience in this matter. Thank you so much. And last but not least, our next panelist member is Miss Deborah Davis. She has been a mammographer for as long as some of us have been alive here on Earth, for 30 years. She was a lead mammographer at MD Anderson Cancer Center for over 25 years until she retired. And she has performed diagnostic and screening exams, stereotactic breast biopsies, breast localizations for preparation of patient surgery, executed quality control, and worked on the mobile mammography vans. She has taught continuing education in mammography since 2006 and created also a mammography curriculum at UT MD Anderson School of Health Professions. She shares her compassion for breast health and, of course, loves to share her experiences and knowledge for future generation mammographers. Thank you, Ms. Davis. We pulled you out of retirement to share your knowledge, and we thank you for joining us today. Thank you all. All right. And I've got the mic, the invisible mic in my hands, and I'm going to ask us questions. So feel free to unmute yourselves. I'm going to go with our first mammography recipient, Dr. Veronica Ajewole. And my question for you is, as a first-time mammogram recipient, what motivated you to get screened?
Awesome. Thank you so much, Dr. Obo, for that great question. And thank you to all the audience for joining us this afternoon. So like one of the slides Dr. Obo shared was about the screening recommendation and the screening age. I am privileged and, with every sense of humility to say that I am an average risk woman when it comes to my breast cancer risk. So I was not necessarily, there was no recommendation for me to receive screening mammogram until the age of 40. I turned 40 last year. And so it's almost like, okay, here it is, right? You need to go for what you've been preaching, all along. I have had the honor to preach to the choir. I've been leading breast cancer screening prevention programs for many, many years, since 2018 to be specific. So the clock finally clicked last year when I turned 40. So it was almost like, okay, now you have had the privilege to say this in the church, in the community, on multiple platforms for women to receive their screening mammogram. Now you're 40. Okay, why not? Nothing stops you. Just go ahead and do what is needful. So for me, it went beyond. It was something that I actually looked forward to because when we had this screening mammogram, a painful experience last year or 2 years ago, there were a lot of questions. And I'm like, okay, I have actually never had a mammogram before. So, all I could say was on what I've been, the shared experience that other women have told me, this is what I can expect. But it was just, more like, okay, the time is here. You're 40. Just go ahead and now stop preaching to the choir. You'll be the choir yourself, type of a thing. So that's really what led me to receive my mammogram last year.
Thank you so much for that, Dr. Ajewole. And I want to encourage, if there's anyone who just turned or is turning 40 this year, this is the spur you need to please do the needful. Then I'm going to ask Miss Weston, for someone who is preparing for her very first mammogram, how should she plan? What should she wear? And what should she avoid? And what should she expect during such a visit?
So we want them to try and wear a comfortable two-piece outfit. It's a lot easier, and sometimes if they wear dresses, it can be a little bit more revealing than needed. So we recommend that they wear the two-piece outfit. Avoid wearing any deodorants, lotions, or powders on or around the breasts and underarms, just because sometimes there's aluminum within the deodorant. So we have them remove that because any metals will show up in an x-ray. And then, of course, any powders or lotions can cause some artifacts within the actual image itself. Preparing for their visit, especially a first-time visit, can always be a little nerve-wracking. So we recommend that they do their research if needed, or call and ask us any questions. We could be happy to help them.
Oh, that's great. Thank you so much. So call and ask if you have any questions, please, rather than not showing up at all. Miss Davis, my question to you is, over your 30 years of experience, right? What are the most common concerns or fears that patients share before their mammogram?
Well, thank you for having me today. It's such an honor.
Thank you.
It's a great question. The number one fear usually is radiation. And we here, I am at work today. Even though I'm retired, I'm at work. We explain to them it's a very regulated dose, and that we explain in terms they can understand, like about a month walking around on the earth with background radiation. And that also their concerns are the compression. So we have signs up in our room explaining in layman terms why compression is so important. There's 7 benefits of compression. And the number one is to get even thickness throughout the whole entire image for good contrast and even penetration, and also reduces motion, reduces radiation, and it separates overlap tissue so we can see in between the structures of the anatomy of the breast to where we can find small details of possible pathologies, whether they're benign or cancerous. And so we have signs up to explain to them, but mainly their concerns are radiation dose and the compression. And we give good explanations under terms they can understand to explain that to them. But those are the biggest concerns.
Thank you so much. I was talking to myself for a minute right there. But Dr. Ajewala, I'm going to go back to you. Can you walk us through your typical, your first experience when it came from arrival to completion? How was that for you? Any nerves, and then how comfortable were you doing the procedure?
Awesome. Thank you, Dr. Obo. And, this is again another place where I had to preach to the choir. So my birthday is in March. I have a birthday coming up a few days from today. So I had scheduled my mammogram a few days after my birthday. And guess what? I was late. Okay. My mammogram was in clinic. It was not on a mobile unit. So, I was running late from meetings and whatever. So I showed up maybe about 5-10 minutes late. And the ladies there, they still checked me in. And they were like, oh, all right, you'll be okay, go in. I sat in the waiting room for over an hour.
Oh, wow.
It was not, and I'm not going to tell, the healthcare system that I went to. But I'm like, okay, I need to go pick up my kids. Okay, the daycare is going to charge me $50 extra for, running late to pick up my children. So I had to leave. I had to leave, and it was a bit of a unpleasant customer service experience for me. Let me just put it that way. Of course, I was late. I took responsibility for being late, but the healthcare system itself, they told me, okay, we'll walk you in. But then for me to have been kept in the back room for over an hour was not just pleasant. And then I needed to reschedule, which took me another 6 schedule is tight. So I ended up not, having my actual mammogram until maybe late April. That was when I eventually did the mammogram. But when it comes to the experience itself, it's just like, showing up for any regular, doctor's appointment, checking in, doing all the necessary paperwork. And then they would guide you, to make sure that, you change to an appropriate clothing. And then, the back room was very comfortable, water, very comfortable space, nice music, very relaxing, because of course there is that, anxiety, what have you. So the physical space itself was very welcoming, and it definitely eased my mind as the first time that, that I was getting the procedure done. And then moving along, well, while I waited, completed a few surveys, just like, we would typically do in most clinic setting, completed a few surveys. And then the lady came to get me to actually, go into the room to receive the screening mammogram itself. What surprised me the most was the coldness of the equipment. Brittany and Deborah, you guys are used to it, but I was not used to that. I was not expecting, and of course, I was already, undressed top, off. So now being put into the machine, and the machine was cold. I'm very sensitive to cold. I'm like, "Woo." I'm like, oh my goodness. I think that was a bit of a shock for me. I wasn't expecting to have that direct contact with a cold surface. The way it happened, I think maybe just being informed, like, hey, watch out, this is going to be a little bit cold, would have helped me, to just mentally prepare a little bit. But other than that, I think the discussions we've had, the webinar, we had the part one of this webinar already kind of helped me. Deborah, Brittany, if you guys remember, I was the moderator for that. So I already kind of checked off my own questions, right? So, okay, this is what to expect, the compression, and I wouldn't say it's pain, it's more of a pressure. And I knew why. And the mammographer was also very gentle. She kind of walked me through, okay, this side, all the tilting and, how to position myself. It's more of a little bit of a discomfort temporarily that was bearable. It wasn't anything that, was not bearable. And I give my full disclosure, saying that I moderated this panel a year ago or so. So I'm a bit more informed, in that sense, maybe than most women. But the only aspect that I was not expecting at all was the cold shock. And I'm personally very sensitive to cold. Like, I get cold. My office is also very freezing right now. So I get cold very easily. So it was just that temperature change was a bit of a shock for me. And then, and like I said earlier about the whole customer service experience for me because of me arriving late. And the back end too was that first visit, I ended up being billed for it because I checked in, right? I checked in. So for whatever reason, the billing folks billed me. So when I went in for my real mammogram, the insurance kicked it out saying you can't have 2 mammograms in a year period. So then I had to fight some insurance battles, to dismiss a claim and, pick up a real claim. So I had some unpleasant customer service, billing stuff going on, but that was a healthcare system challenge and not necessarily anything specific to the mammogram, the screening mammogram that I received in and of itself. So I'm almost like, oh, maybe I need a patient navigator now, right? To help me dismiss my, my wrong claim, on my insurance, but eventually everything was taken care of. And I'm glad I went through it, and I definitely, recommend, every woman that is of age, average risk or high risk women to please prioritize, because I had to make that decision to say, okay, with scheduling, I apologize, I was late, but I could be better. I could have showed up on time for my initial.
Thank you very much, Dr. Ajewole. Ms. Weston, what steps, as a follow-up to what she mentioned, what steps do you take as a mammographer to help your patients feel comfortable and less anxious during the procedure?
So for me, I talk to my patients and I explain everything I'm going to do. I don't want them to ever be surprised. So I will let them know this is going to be a little bit cold, or this is the steps I'm going to take. As I'm reviewing with them before I do anything, I said, if you have any questions at any point, just let me know. I tell them as I'm positioning, it should not be painful. If it's painful, let me know and I can reposition or I can adjust, because it shouldn't be painful. It should just be that pressure or discomfort for just a few seconds. It should never be any kind of pain. So I always am communicating with my patients. I'm never completely silent. As I'm going, I'm letting them know, and also opening that communication where they can also talk to me and let me know if there's any discomfort or anything like that.
Right. Oh, thank you so much. And that is good to know. So please, there is communication. And I have had quite a number of those as well. And I would have to say that there was also communication going back and forth. So I knew what to expect because they made me aware while that was going on. And like you rightly said, there is no pain. There was no pain, or there has been no pain, just the discomfort. So I can attest to that. Ms. Davis, I've not forgotten you. How have you seen changes, in technology or call or technique, right? Also over the years that have improved patient comfort. And if you don't mind also alluding to the fact of the compression and and all that.
Well, thank goodness that the manufacturers for mammography machines have kept up with the technology and changes and formatting of the detector.
Mm-hmm.
One, the detector is more rounded in the corners.
Okay.
It used to be square sharp, like when we had film screen technology. Of course, with digital, that was approved in 2000. They had changed some of that. Also, they do have new paddles that have been created with different manufacturers called comfort paddles, or they have different names with each manufacturer, where they're curved and not straight, that
Okay.
can conform to the roundness more of the breast. And also we have tools, like I had brought this to show you this. It's hard to see, I know, with the background, but this is a mammography cover that
Okay.
helps with tearing underneath at the IMF, where the breast attaches to the abdomen, the inframammary fold. And we use this for larger breasted patients to keep it warm, Veronica. And also it's clean. And it is a little cushiony. It's not like the mammography pad.
Mhm.
These are created, like this is from Beakley. The pad is owned by Hologic. And so they are different tools that are used to help with positioning, make it more comfortable for the patient. Like I said, along with the detectors being more rounded and different types of paddles that each manufacturer creates. They even have this new paddle with Fujifilm that compresses not only side to side, but it compresses front and back. So it really conforms more evenly and creates a more uniform pressure compared to like more focal pressure on the breast. And so the manufacturers are listening to consumers about the discomfort and really working to improve their engineering on the machines.
I'm so happy to hear that. Thank you. Yeah, yeah. Now you spoke of you spoke of like the breast size and whatnot. Miss Brittany, I'm gonna go to you for this question. Does breast size or breast density affect the experience for a woman in any way? Either if it's too big or too small or whatnot, and the compression as well. Does that have any effect to the experience a woman has?
It definitely can. So a lot of our patients, they'll say, "Is it my breasts are bigger? Does this mean it's going to hurt more, or if it's smaller?" Um, it's what the breast size for me personally. I let the patient know. Typically, the more relaxed they are, the less it's going to feel as painful. So size shouldn't really affect it, but breast density can very much affect the amount of compression or the amount of pressure they will feel. The more breast density or the higher breast density that they have, they can definitely feel a lot more of that compression. You have more tissue that needs to be compressed versus like a fatty breast. There's the lobules and everything like that that are just not as not as much compression is needed on a fatty breast versus a dense breast.
I guess that makes sense too. So thank you for explaining that. I am going to ask you, Ms. Davis. I know in my lecture or in my previous education of a few minutes ago, I mentioned about a mammogram. But I know with technology also there have been changes, or should I say, changes to the pictures, which is what an X-ray is. right? In taking of mammogram screening. So my question for you is, can you explain the difference between a standard 2D mammogram, a 3D mammogram, and an ultrasound? And does this experience vary depending on what you are doing on the imaging you're getting?
Yes, ma'am. 2D imaging was created and approved by the FDA in 2000. So it's been around a really long time, 26 years. And there's many different manufacturers that have been approved by the FDA for 2D imaging. And that's where the X-ray tube just is at 0 degrees. It goes directly straight to the breast. And the number one problem with 2D imaging is superimposed breast tissue that can hide pathologies in the breast. Even though we do common different projections where we put tissue in different places on these projections, the number one is still superimposed breast tissue. Well, when 3D was approved in the United States in 2011, it was amazing because not only do we, by law, MQSA laws, have to do a 2D mammogram along with 3D, so we get both benefits. The 3D, the tube is angled off of the 0 axis and takes different angles depending on the manufacturer. It's all very different. And off of those projection images, which are angled off 0 axis, the computer steps in and separates those projection images into slices, tomosynthesis slices, to where you don't have overlap tissue. Now, it's not 100% specificity, meaning you find the pathology is 100%, but it is raised with just 2D alone. It is raised immensely with 2D and 3D. And it, it does have some drawbacks. The contrast is lowered. It is more dose, but it's still very regulated and very safe. Otherwise, it wouldn't have been approved by the FDA in the United States. And the benefit outweighs the extra radiation. And now they do have a synthesized view where you don't have to take the 2D. A computer creates a 2D image from the tomosynthesis images. So the technology is very good. In the United States, there's over 26,000 mammography machines. Unfortunately, only half are 3D, and it's been out since 2011.
Oh, wow.
And the cost is the biggest deterrent to purchase 3D for, these facilities that are just trying to stay afloat to be able to perform mammography. And that's the drawback, is the price, because they're highly engineered. You have service contracts that you have to sign different levels. But 3D and 2D performed together do find more breast cancers. It's proven with all the clinical trials. And it is better, but unfortunately, like I said, not even half in the United States. And there's other reasons maybe they don't have 3D. It's not all just finance, but that's the number one issue. And with ultrasound, yes, ultrasound, even along with mammography, does find more pathologies.
Okay.
Unfortunately, ultrasound can't see the small microcalcifications. So that's the sad part. Mammography still is the gold standard in the United States to find breast cancer at the earliest stage possible compared to any other modality alone. And but ultrasound does help correlate pathologies along with 2D and 3D mammography. But we are so excited. And we also do contrast enhanced mammography. That's the newest, even though it's been approved since 2011. It's really becoming very popular in the United States. We do it here at MD Anderson, but where we inject them with iodine, just like in CT, iodine contrast, and it shows enhancement and really replaces MRI, because a lot of patients can't have MRI for some reason or another. And so that's like a whole, you could talk hours on contrast enhanced mammography, but that we're excited about that too.
Okay. Thank you so much for explaining that. I mean, I had a follow-up question that came to my mind that I think maybe somebody might have at the back of their head when you mentioned about the 2D and 3D and about how half the centers or half the machines here in the States are just 2D as opposed to being both 2D and 3D. What came to my mind was videos like, black and white as opposed to colored. It looks better when you're watching colored movies as opposed to watching black and white movies. The film is just better. But I think a follow-up question I had that somebody will have hope is when it comes to insurances, because of course we know what the issues is with healthcare. In your experience, have you seen that some insurances will only want a woman to do just 3D as opposed to 3D and 2D, or universally, if there is a 3D, they'll pay for 3D?
That's a good one. That's a good question with insurance. Unfortunately, each state has different rules with what they cover with insurance or not. Medicare does cover a 3D screening mammogram, not necessarily diagnostic. They kind of question it. But each state has their own rules with insurance. And many states have mandated, start out as a bill, turned it into law with mandating to pay for 3D because that's proven to be better. And if that facility only has 3D mammograms, it's not fair to that patient to where their local screening mammography facility only performs that they can't have that. Now, at the beginning, we made them pay $50 extra because it did not have a listed code, a hospital code. But then it did come around about 2015, I think it came around where there's a listed code for 3D mammography. And we tell the patients, if there's a question, call your insurance before we start. We try and tell our patients when we schedule them, please check your insurance to make sure they cover 3D mammography. But if the patient refuses 3D mammography, we just do 2D mammography for them. And we put in the notes for the radiologist that patient refused 3D and only wanted 2D.
Okay. Oh, that's good to know. Thank you. I have a question from an audience member, and either you, Brittany, or Ms. Davis, please, either of you are free to answer. And the question says that, are there any new developments coming to make the mammogram more comfortable? Any other developments to help with dense breasts?
So they're always working on something. I'm not familiar with anything upcoming, but I do know that the curve paddles, or the comfort paddles, as Deborah had called them, those have been the newest update that we've seen in terms of trying to make it more comfortable experience.
Awesome. Thank you. Ms. Davis, did you have anything to add, or did I suffice?
Yes, and also they've come, Coning manufacturer does have a CT at the breast. Unfortunately, a lot of insurance aren't covering it, and the availability of it is very few in the United States. And it was approved, I think, 2017 in the United States. That you just lay down and your breast falls through the hole, and they do a CT where you lay on a table. That has, it's another alternative with mammography, of course. It's a more diagnostic tool to work along with mammography. And, there's many different tools, but that's just the other one compared to what Brittany had said. Yeah.
Thank you so much. I have just one more question to ask before we round it off for today. And thank you so much for being so gracious hosts. One more question, and it's sort of like a two-part question. For a woman who is still experiencing a menstrual cycle, is there any kind of thing a woman should know about getting screened as regards to maybe the time when she is on her period? And then also for the person who is who maybe has a fear of pain or being uncomfortable, is there any advice in terms of taking over-the-counter medications that we will tell such women?
Yeah, the best time for a mammogram is like 14 days after the onset of her menstrual cycle.
Okay.
Now, unfortunately, you schedule the mammogram even a year in advance, and you don't know exactly when your menstrual cycle. Some patients do choose to take pain reduction medications such as aspirin or Tylenol before their mammograms. to reduce the discomfort because, you know, you can get fluid-filled cyst more on your periods. That can make it more discomfort. And if they want to reschedule to where they aren't on their menstrual cycles, it's fine. We try and reschedule that patient to accommodate them to where they had the least amount of fluctuation in their breast with swelling and pain. But 14 days after the onset is the best time for them to have it.
Well, that makes perfect sense. Ms. Weston, did you have anything to add to that? I think I saw you trying to come off mute.
No, I completely agree with Deborah. We recommend about 2 weeks after the onset of your period. We do get some calls from patients like that request to reschedule just because they do have increased pain around that time, and we accommodate as needed.
Thank you so much. I appreciate your feedback. And I have one more question for you, Dr. Ajewole. You're going to help us round it up as you are the principal investigator and the program director of this, our breast cancer screening prevention program. You know, the whole thing, why you spent nights, you know, writing this grant, how many hundreds of pages, right? And get this funding to provide screening for our women, our both uninsured and underinsured women. So for that woman who still, it keeps putting off her mammogram, right? What would you say to such a woman?
Thank you so much, Dr. Obo. I mean, the message is, let's just do it.
Let's do it.
Let's do it. Let's just do it because the discomfort is, I mean, mammogram, yeah, there is that discomfort, right? You know, we've talked about it. We've talked about ways to reduce it, you know, to manage your expectations. That's why we're having this conversation to help make people more informed, right? When you're more informed, you feel more comfortable in what you're doing. But at the end, I still had to make that decision to schedule myself. And even when I ran late and I had to reschedule, I had to redo it, right? You know, I had to. So we all have conflicting priorities. And my own case is that typical case where I'm like, okay, yeah, I scheduled my mammogram and boom, I showed up late because I was caught in traffic. And then ended up waiting for an hour. But eventually I was scheduled and I got it completed. So the message here is clear to say, please just do it. Just the benefits outweighs the risk. And you know, with screening mammogram, there is the chance for early detection. You know, within our program, we've screened almost 2,000 women, and we diagnosed women with breast cancer. Yes, unfortunately, we've had breast cancer diagnoses, like you can imagine, after screening almost 2,000 women. The good thing, however, if I could put it that way, is that several of these women were diagnosed at an early stage. We've had a few, you know, late stage diagnoses, but most of these women who are asymptomatic, you know, who have been diagnosed are diagnosed at an early stage. So the whole idea is, let's do it. Let's give ourselves that chance to live longer, to, you know, live a life that has a good quality. And that if at all, if there will be any, you know, diagnosis of any kind, those diagnoses can be identified early. So please don't put it away. Don't undervalue the importance of a screening mammogram or any form of health and wellness check. Make time for it, create room. And our team, specifically here at TSU, we are happy to guide and call and schedule and help walk you through. And we have these amazing experts, Deborah and Brittany, right? They've shared with us, you know, some of those key nuggets on what will make that first time screener, or if you've not screened in the past several years. If you have questions, if you have doubts, we are here to support. And let's just do it. And Dr. Obo can sing a song of let's do it.
Thank you so much, Dr. Ajewole. I'm sorry, I did not lie. I did not lie. We were done, but there's a question that just came up now, and I really want us to answer it just quickly for this person. And it says that, what about a 19-year-old with a breast lump that has pain for 2 years who was denied a mammogram? What can you suggest? How can we suggest navigating and whatnot?
So here for us, we always follow the recommendation and the requests of a patient and a doctor. If the patient is wanting a mammogram and the doctor is also wanting it, we will perform that mammogram. We've diagnosed women as young as 21 years old with breast cancer, so we won't deny doing a mammogram if that is truly what the doctor and the patient are wanting.
Yeah,
Okay. All right.
we don't do it here. We start with ultrasound and MRI, radiation modalities first. Then if they see something, then we'll come back with the mammogram. We don't do them that young. 25 and older is our protocol, but I know every facility has different protocol.
Okay. All right. And the last question here is that, can trauma cause breast cancer? Somebody's asking, should people avoid things like breast augmentation or heavy lifting to reduce chances of breast cancer? And this is going to be the last question.
It's a good question. Trauma can cause like fat necrosis in the breast, which is scarring. Patients with implants, blunt force can rupture the implant. But as far as cancer, I'm not sure about that. But as far as scarring, yes, it can cause trauma to the breast with scarring.
All right. Thank you so much. Thank you. And on that note, I'm going to thank you all for your time. Thank you for joining us, for giving us 1 hour of your precious time and some of us of your retirement to enlighten our participants today. And thank you also to our attendees who joined us online. You might have been eating or whatnot, but I know you've gotten 1 or 2 things that you can feel enlightened and empowered for. If you can do us a favor, please go on to the next screen. Next slide. If you can do us a favor, please to fill out our survey. It's important for us to get feedback on how we did, on what we can do better. Our community health workers, thank you for joining us. To get your free 1 hour of CE credit, please fill out the survey and the evaluation, and we should send you out your certificate under 2 weeks. Again, thank you for our Facebook and YouTube audiences who have joined us. We appreciate you. And at your free time, please go ahead and engage with us in our website as well. You can email us as breastcenter@TSU if you have any questions, and go ahead and also review our link tree. There are so many information in there that you can learn of. Next slide, please. Now, moving on to our next event. We are full of events here at TSU. Under the leadership again of Dr. Veronica Ajewole, we're having our annual Clinical Research and Engagement Conference taking place Saturday, April 18th. And this time is going to be in the Cypress area. It's taking place at the Richard and Meg Weekly Community Center. It lasts for over 6 hours, but there'll be some lunch. There'll be lunch provided, and I believe light breakfast as well. Please share this. You can join us in person or virtual, and would love to just share with the community what is going on in research. Try to debunk some myths in there, and enlighten our community some more. And the other events taking place, next slide, is save the date, of course, for our two breast cancer events. We are having our next quarterly webinar also via Zoom, titled Thriving Beyond the Diagnosis, and just talking about life after breast cancer diagnosis. It's going to be a solely panelist session whereby we're going to have survivors share their experience as well as a healthcare provider. So please mark the date, June 10th, 2026, between 12 noon and 1 p.m. And we'll provide more information about this. Also, our annual breast cancer, We Roar Against Breast Cancer, taking place here at TSU campus, October 30th, between 11 a.m. and 3 p.m. There will be so much festivities going on. There will be panelist sessions. We're going to be honoring some survivors. We're going to having some pictures, some band members singing, eating and drinking, and so many festivities going on around breast cancer. So please don't fail to join us, and we appreciate you for your time. Thank you. Next slide. Again, if there's anyone who knows of anyone that would like to partner with us in bringing about the TSU Mobile Health Unit to provide preventative services as well as mammogram services out to our community members, please feel free to to send us an email, either through our breast center email, or even there is some links in our link tree that we can share more information with you about. Next slide. And again, of course, we are still interested in signing up community members, anyone who is interested in, learning more about our clinical research program. Just scan the QR code and somebody will reach out to you in less than 2 weeks. And lastly, on behalf of Breast Cancer Screening Operation Center, thank you. Again, we do provide no cost, convenient screening and diagnostic mammogram services to both our uninsured and underinsured women in Harris, Grimes, Malagoda, Walker, Wharton, Brazoria, Galveston, Polk, and Tricis County. We also provide patient navigation and barrier reduction services. And we work, of course, with both the Rose and MD Anderson. So we thank you both. Thank you, the Rose. Thank you, MD Anderson, for providing, your support to us and for providing of your staff and your time to us to make this experience a great one. On that note, we'll see you all in June again. Thank you all.
Thank
Bye-bye.
you.
Bye, everyone.
Bye.